Welcome to AUA Leadership in Business, an official podcast of the American Urological Association.
Welcome to the AUA Leadership in Business podcast, where urologic professionals experience the practical application of business acumen essential to successfully navigating today's rapidly changing business environment. I'm Dr. Jennifer Miles Thomas, and in today's episode, we will discuss some of the most common and often complex regulatory issues faced by medical groups today. Joining me today for this discussion is Lou Glaser, partner at Katten Muchin Rosenman LLP. Mr. Glaser has represented healthcare providers for over 34 years. He concentrates his practice on corporate, transactional, and regulatory matters. He represents a wide variety of healthcare providers all around the country, including some of the largest medical group practices. Mr. Glaser has been named among the best lawyers in America, Health, each year since 2003. He has been selected by his peers as a member of the leading lawyers network, Health Law, each year since 2004. He has been named by Nightingale's Healthcare News as one of the country's outstanding hospital lawyers and outstanding healthcare transactional lawyers. Mr. Glaser earned his Bachelor of Arts from DePaul University in 1984, his Master's of Health Administration with a concentration in finance from The Ohio State University in 1986, and his Juris Doctorate cum laude from Loyola University Chicago School of Law in 1989, where he served as editor-in-chief of the Loyola Law Journal. Mr. Glaser also has a certificate of mediation from the American Health Lawyers Association. Welcome, Mr. Glaser.
Thank you, Jennifer. How are you?
Doing well.
Good to see you.
Good to see you too, and thank you very much for joining us. This is a topic that I think we all need to be educated about. So we'll just jump right in. And one of the first questions I do have is regarding the federal Stark Law. As professionals, as health professionals, as physicians, we frequently hear this term, but it seems very complex and somewhat convoluted. So what do you see that most groups have difficulty either understanding, and what parts are the most complex?
Well, certainly what started out, I think, as a simple concept has evolved into one of the most complicated regulatory schemes. The idea started in, the mid 80s with Representative Pete Stark, for whom the law is commonly named, referred to as the Stark Law. And the idea originally was that physicians who owned an interest in clinical laboratories tended to refer more patients and tests to those laboratories than those that weren't owned by physicians. And so Representative Stark passed a law that said if a physician has a financial relationship with a clinical lab, he or she can't refer Medicare patients to that lab unless an exception applies. Well, soon after the introduction of the law, it was expanded to cover what we now call designated health services, which are 11 categories of services that range from not just clinical lab, but include imaging, all hospital inpatient, outpatient services, outpatient prescription drugs, radiation therapy, and I could go on and on. And I think one of the most common problems that people have with the Stark Law is understanding what services and items are covered by the law, right? We can look at these 11 different categories and people think, oh, well, imaging, I know what imaging means. But to really understand what is covered in the scope of the law, at times you have to get down to a very granular level, to the level of the CPT code, for instance. There's some categories of designated health services that are broad, as I said, inpatient, outpatient hospital services, but there's some where you get down to the CPT code level and all services within a range of CPT codes are included, but then some are excluded. So you can never say for certainty without looking at those codes, oh, I know exactly what is a designated health service. And we see this come up all the time because groups try and be compliant. They try and structure their compensation system in a way that complies with the exceptions. And then lo and behold, they find out that something that they didn't know was a designated health service, they've been handling in a different manner. And, it's important to keep in mind that the Stark Law is not an intent-based statute. We'll talk a little bit about the anti-kickback statute. It doesn't matter whether you intended or didn't intend to comply with the law. If you have a violation, it's a strict liability statute, meaning that unless you fit an exception to the letter of the law, you have a violation. The other thing that makes the law so complicated is, as I said, you have to fit an exception if the prohibition applies. And at this point, there are dozens and dozens of exceptions. The reason being that over the years, as the scope of services that are covered by the law have expanded, the kinds of arrangements that the government deems permissible have also evolved. And so we see this most recently, for instance, when a lot of value-based care programs were introduced, and people looked at them and said, well, technically they don't fit within one of the existing exceptions, but they shouldn't be problematic. If the goal of the law is to keep people from referring or ordering more items or services because of an economic interest, value-based programs tend to have the exact opposite incentive to order less. And so therefore, they don't create the same problems that the statute sought to prevent originally. But we had to create a bunch of exceptions, or CMS had to create a bunch of exceptions in order to capture those arrangements within the regulatory scheme. The other thing that's important to keep in mind is a lot of states have enacted their own version of this federal law. We often refer to them as son of Stark laws. And these can be very different from the federal law, covering different kinds of services, covering different exceptions. And so when you look at an arrangement that you're considering or that you have in place for compliance, you have to look not only at the federal level to make sure that you're compliant, but also at the state law level. And that can introduce another level of complexity, because people think if I'm complying at the federal level, I should be fine at the state law level. And in some states, that's the case. They essentially pick up the federal exceptions, but in other states, they're completely different. The area where I think outside of these broad parameters, most groups struggle tends to be in what's called the in-office ancillary services exception, or what people often refer to as the group practice exception. The notion here is that when groups offer services for their patients in their offices, then that's really for the convenience of patients. And as long as certain requirements are met, that should be permitted. It shouldn't be a prohibition simply because a physician is an owner of a medical group or an employee of a medical group. As long as you satisfy this exception, your compensation arrangement with the group should be permitted. Now, that sounds simple, but I think, as you know, and many people out there know, the devil is in the details, and your compensation systems have to be structured in a particular way in order to satisfy the definition of a group practice and then ultimately this exception. And again, therein lies one of the areas where we see a lot of groups having issues. And particularly when you're trying to allocate the profits from these designated health services to the owners or the owners and employees of a group, groups often stumble in how you do this. And they do it in a couple of ways. One, we've already mentioned, and that is, what is a designated health service? There were some changes to these rules, or as CMS would put it, some clarifications to these rules a couple of years ago, where they clarified that if you have a profit pool from designated health services, that pool has to be comprised of all of your designated health services. You can't have one pool that involves, say, imaging and radiation, and another pool that involves drugs and DME, durable medical equipment. You have to put them all in a pool. And so again, sometimes people aren't aware that certain items or services are designated health services. And if they create a pool thinking they have them all, but some fall outside, you often have a problem. Second, people have often heard of what's commonly called the rule of five. And that says that when you calculate profits from designated health services, you can calculate them on the basis of the entire group, which means an entity or tax ID. But you can also calculate them on the basis of any subset of the group, as long as that subset is comprised of at least 5 physicians. Most groups are aware of this, and they try and structure these subsets to the extent that they have them, whether they're pods, whether they're location-based groups or otherwise. But they sometimes run into problems because sometimes a group will drop below the 5 physician level. Someone retires, someone leaves the group, and then lo and behold, you find that you have a subset that doesn't consist of at least 5 physicians. People are often confused about, when I say 5 physicians, does that have to be owners? Does that have to be physicians who share in the pool? And the answer is no. It's 5 physicians who are part of the group, but not all 5 or more have to share in the actual distribution from that group. The other area where we see issues is once you've comprised a designated health services profit pool, you have to allocate those profits in a manner that doesn't directly relate to the volume or value of referrals of designated health services. And sometimes groups have very complicated formulas. Sometimes they're as simple as per capita. Sometimes they're as simple as relative productivity. But in calculating relative productivity, you can't take into consideration designated health services themselves or things that would be designated health services if reimbursed by Medicare. And so therein lies a lot of problems that we see when groups go to calculate their relative productivity formulas. They inadvertently include things in the measure that they should not include. The result of the complexity of all of this and non-compliance is really draconian. If you read the penalties, you shouldn't be reimbursed, and the government should not pay for referrals of these services or items that are made without an applicable exception. What makes it even worse is whistleblowers out there. So these are people who, on behalf of the government, can bring actions alleging violations, really bootstrap Stark Law violations into Civil False Claims Act cases, saying that these claims were presented to the government improperly, and the damages under a Civil False Claims Act can be treble damages plus up to $22,000 per claim, where every $1,500 is a claim. So the numbers get big very, very fast. The good news, if there's good news in all of this, is that CMS offers a self-disclosure protocol that allows you to disclose a violation. Again, doesn't matter whether it was intentional or not, it's still a violation, and to settle with the government really for pennies on the dollars, a small percentage of the total dollars that were billed without an applicable exception. The bad news about this process is it takes years. Currently, it's taking about 5 years for someone to work entirely through the process, but it does provide an avenue for someone to try and rectify a problem in a way that is not nearly as expensive as a whistleblower case.
Well, that seems fairly complex. Thank you for making it as simple as possible. I think definitely the complexities of assembling a fair compensation model based on productivity, our radar needs to be on of what are we including in that productivity. I think that's definitely something that I hear about, and we all should be aware of making sure we definitely have our final comp plan vetted prior to enacting it.
And I think there's another aspect of the rule that CMS created a couple of years ago, recognizing that groups oftentimes have full intention of complying. They draft their compensation arrangement in a manner that is fully compliant, but then in execution, things fall through the cracks. And there is the ability within certain narrow parameters, if you find that there is a discrepancy between what actually occurred and what's written in your compensation plan, which is compliant, the ability to, as we like to say, put the toothpaste back into the tube and address this exists. Again, it exists within narrow circumstances, but it's a reason why groups should monitor what they're doing, check every so often to make sure that what they're doing in fact follows the plan and in fact is compliant.
Sounds like a good plan. Well, a lot of times I've heard people confuse Stark with anti-kickback. They're different, right?
Very different for a lot of reasons. As I mentioned, the Stark law is complicated. It is a strict liability statute. Your intent does not matter. It's also a civil statute. No one really goes to jail for a Stark law violation. But on the other hand, the anti-kickback statute is incredibly broad. It is intent-based, and it is a criminal statute. When I say broad, I often say you can read the anti-kickback statute as if anybody offers, pays, solicits, receives anything of value intended to induce referrals of governmental program business. That's in theory a violation of the anti-kickback statute. The old joke was, you could put out free donuts and coffee at the hospital, and that would be an anti-kickback violation. So as a result of how broad it is, and given that it's an intent-based statute, unlike the Stark law, which has these dozens and dozens of exceptions, what the government has done is create safe harbor regulations. And there are very few of these, really, relatively speaking, where if you structure an arrangement to fit within a safe harbor, then you are free from prosecution. I think one of the common misconceptions out there is if I fail to meet a safe harbor, that means I violated the anti-kickback law. And the answer is no. Failure to meet a safe harbor doesn't mean that you violated the law per se. It simply means that you aren't within this area of protection. Your arrangement is still subject to facts and circumstances analysis. And at the end of the day, an intent-based analysis as to whether or not that intent is in place with respect to the arrangement. That said, anti-kickback statute also gives rise to whistleblower cases we talked about in the context of the Stark law. People use the Civil False Claims Act. They bootstrapped arrangements where someone says, oh, this arrangement violates the anti-kickback statute, and therefore each of the claims that were submitted pursuant to this arrangement are again civil false claims subject to treble damages and $22,000 per claim. So pretty draconian. Mm-hmm. There is also a self-disclosure process with the Office of the Inspector General under the anti-kickback statute. It's not going to be as favorable as the CMS Stark law self-disclosure protocol, and settlements under it tend to be for much higher amounts, oftentimes including multiples of dollars that were improperly paid or received. We still see the need for analysis on these arrangements. They go beyond simply the designated health services under the Stark law and different arrangements like that. And so it's important to recognize that simply because you've looked at something from a Stark law perspective doesn't mean that you've necessarily satisfied the anti-kickback statute. And as with the Stark law, there are state parallels to the federal anti-kickback statute. Some states, they apply to Medicaid programs only. Some states, they apply to all payers. So again, you've got to be attuned to not only the federal level of regulation, but the state level of regulation as well.
Yeah, it seems clear that the devil is in the details. I know as physicians, we're frequently solicited to by all these different companies with these different programs and products, but it seems critical that we definitely engage in due diligence because it seems at the end of the day, we're the ones who are vulnerable.
Well, and I think you see this a lot with vendors that you deal with. And it's important to keep that in mind, right? A lot of times people think of kickbacks as, oh, well, wait a minute. Somebody is simply paying me for a patient or for a referral in the traditional sense. But oftentimes there are incentives that are given in connection with signing agreements. And so that's where you go back to, offer, arrange, solicit, receive. The law is very, very broad. And so if a vendor comes to you and says, really interested in selling you a particular product, and what I'd like to do is I'd like to take you out to a really nice dinner, and followed by tickets to a sporting event, right? All of these things can be inducements in order to get you to sign the agreement with the vendor and thereby enter into an arrangement where there are referrals or business generated that are reimbursed in whole or in part by a federal program. And so a lot of groups need to pay attention to their vendor relationships, their purchasing arrangements, and making sure that everything that the vendors are doing is appropriate. And just the same, everything the group is doing for referral sources, right? Mm-hmm. Just like a vendor offering you something, if a group says to a referral source, we'd also like to take you out to a nice dinner. We have really nice tickets to a sporting event or a concert, right? Those things can be potential violations of the law. So I always conclude by saying, just remember, it's just as improper to give as it is to receive.
That's great advice. Well, what other area do you see most groups struggle, like in the day-to-day compliance?
It seems like more and more we're seeing groups having difficulty with some complex areas in simply the billing and the reimbursement of services. And there are a couple of areas that seem to pop up a lot. And so I'll just try and hit on them real briefly. Okay. One is what we affectionately call the anti-markup rule. So it used to be known years ago as simply the purchase diagnostic services rule, which said that if a group was billing for a service that it bought from someone else, really try and simplify this. So let's say a medical group wanted to bill for an imaging service that was provided by a third party, right? In that case, what Medicare would say is you couldn't mark up that third party's charge to the medical group. So you're limited in your reimbursement to the lesser of the Medicare physician fee schedule or what the third party is charging. Years ago, that got expanded beyond just diagnostic services or the technical component of services, and now includes the professional component of services. And we often see issues here because the way the law has evolved is, let's say you operate a laboratory within your group, but you don't have a pathologist associated with your group, and you contract with an outside group to provide a pathologist, and you say to that outside group, we're going to pay you X dollars per read that you do on our lab tests. The law now applies, even though that's a professional component, because it applies to both the professional and the technical component of these services. And the limitation on reimbursement will apply unless the individual who is providing this service to you shares, the term is called shares, a practice with the ordering physician. That gets into a very complicated test. There are two different ways you can satisfy that. One is based on location. For multi-site groups that have centralized, in this case, labs, it's almost impossible to meet that test for all of the physicians who will refer for the lab tests. And so most look at the second prong, which the second prong is, does that individual provide at least 75% of his or her professional services through the group? If you meet that 75% test, then the anti-markup rule doesn't come into play. So groups often get confused about this. They think, well, number one, if this person is employed by my group as opposed to an independent contractor, I'm totally fine if they don't meet the 75% test. The answer is no. You have to meet the 75% test whether you're an employee or an independent contractor. And groups forget to insist upon this when they use an outside vendor, like a large pathology group that may have multiple physicians who rotate through and provide the professional component to them. So we see this a lot. It's really an overpayment because groups will bill when they don't meet the share of practice requirement. You're not allowed to bill globally. In that case, when you're subject to this rule, you're supposed to bill the professional component, the technical component separately. And it gets into, as you can see from this 2-minute conversation, all of these complexities on both reimbursement and billing. And that's one of the areas that we see lots of confusion in. We're seeing more and more on incident to billing. And I think the CMS is starting to look at this harder. When is incident to billing appropriate? Have you had an initial visit with the physician as opposed to just the APP? And therefore you've established that the physician has had the initial visit, developed the plan of care, and now it's appropriate to bill incident to, versus people who will just have APPs see patients on an initial visit, but still try and bill it incident to. And so the government is starting to crack down on a lot of that. There's some split billing changes when multiple providers see a patient in a facility. Those rules are changing. We see lots of confusion around that. And, these are just a couple of examples of things that we see on a day-to-day basis where people are, again, trying to do the right thing, but the rules are complicated.
Yes, we definitely see. And we also see a lot of the payers are independently credentialing the APPs to get rid of the incident to billing. So things constantly change. Well, if we shift gears just a little bit, there's a lot of activity right now about antitrust, anti-competitive concerns by the government and states. Where should we even focus?
Yeah, I think that a lot of this is the result of consolidation, right? Over the last however many years, we've seen consolidation. It's consolidation between hospitals and physicians. It's consolidation between physician groups. And we're finally starting to see the government take some action. You may have seen in the last month or so a significant action brought by the Federal Trade Commission against an anesthesia provider. And I think most significantly, not just the anesthesia provider, but the private equity fund that financially backs that anesthesia provider. The allegations are, monopolization, using monopoly power to raise rates. And so it'll be interesting to see whether this is the start of more action by the government when we see consolidation in the physician space, or whether this is a unique set of circumstances because anesthesia is a little bit different than, say, a urology group, because most of the anesthesia groups have contracts with facilities. They're paid by hospitals, they're paid by ASCs, and so they're raising their rates for those organizations as payers, as opposed to most groups that are dealing with insurance companies. But again, it's an interesting case because they're going after not just the anesthesia company, but the financial backer of the anesthesia company. We're also seeing, and people have probably read over the last year or so, some initiatives at the federal level to try and rein in covenants not to compete and restrictive covenants. There were some proposals made. I think the market reacted quite negatively towards them because they went very, very far, not just trying to prohibit non-competes within an employment context, which a number of states already do, particularly with physicians, but also with respect to sales of businesses, and whether someone who sells their medical practice can agree to a non-compete with a buyer. And the concern there is, given all the activity, whether it's, amongst physicians or with private equity-backed companies, this would have a chilling effect. And so far, we haven't seen finalization of any of those rules, but we are starting to see the states pick up where the federal government has not necessarily acted. So I already mentioned that a number of states have already enacted statutes that prevent covenants not to compete with physicians or restrict the geographic or the durational restrictions that are included within covenants not to compete. We're also starting to see states create review processes. And this goes back a number of years. We started to see state attorneys general initially get interested in hospital transactions, primarily when a nonprofit hospital was selling to a for-profit hospital. A number of states created review processes for those transactions. Then we started to see those expand. In a number of states, they expanded to transactions between hospitals and physicians. California was one of those areas where we started to see that kind of review initially because there's a concern when the inpatient providers and the physician providers come together, whether they have too much leverage with respect to pricing and the payers. But now what we're seeing is states enacting review or notice requirements for physician-to-physician transactions. Sometimes these, include transactions that might involve, say, a private equity-backed company, but sometimes they involve just physician-to-physician organic transactions. If you have more than X physicians joining together, that is subject to a notice and a review process. So I wrote this down at last check. The following states have created these kinds of notice or review laws for physician transactions: Connecticut, New York, California, Illinois, which will go online next year, Washington State, Massachusetts, Oregon, Nevada. And I think that this is all in reaction to, both pricing and access to services within states. So I think we can expect greater scrutiny of consolidation or integration transactions at both the state and the federal level going forward.
Yeah, and I think a lot of the cases that made the national news that we would have heard about included the hospital and hospital system level as well as the practice level. It's hard to keep up sometimes, just what you can do and what you can't do.
You're absolutely right. And I think there's even a difference of opinion within the physician community as to whether these kinds of reviews are good or bad. The thought in some states is that, as physician groups consolidate, whether it's with hospitals, with each other, or private equity-backed companies, the future for independent practices is under threat. And so you have some sectors within these states where they don't want these transactions. They want, independent practices like everyone has been used to continue to exist and not to be backed by these larger partners. Whereas in the same state, you can have groups that, think partnering with a hospital, partnering with a private equity-backed company is a good thing, and it in fact furthers independent practices. So it'd be interesting to see how it plays out over the next couple of years.
Definitely. Well, I just want to thank you. Like, you have made very, very complex issues, things that we talk about among ourselves, but really, I don't know how many of us really understand, straightforward. And I think this is one of those episodes where people are going to listen multiple times to really try to grasp and understand what we need to think about when we're practicing urology. So officially, thank you.
Well, I appreciate it. I know you all have day jobs, being good caregivers and everything, and this stuff is complicated. But the last thing you want to do is find out that you've accidentally stepped into something that you didn't want to.
Exactly. Well, thank you very much for sharing your time and expertise with us today. And I'd like to thank the audience for joining us, the AUA Leadership and Business Podcast. Thank you.
My pleasure.
Thank you for listening to the Leadership and Business Podcast. We invite you to discover the full range of leadership and business programs offered through the AUA Institute for Leadership and Business. Simply visit auanet.org and navigate to the Leadership and Business tab to learn more.